Well, let me welcome those of you that have joined thus far. I've got 3 o'clock Eastern on the dot. We're going to give it a couple seconds here for people to click off one Zoom and back on the other. So we will be back in a couple seconds. All right, let's make sure we maximize our time together. So thank you so much for everybody joining. If you're in the employee benefits world in any way, shape, or form, obviously this is our favorite time of year with open enrollment. So I know everyone's hugely busy. So we will make sure we are using a great impact of your time today. So a couple of things that we're going to start off with, a little bit of housekeeping. Use the Q&A feature. If you've not been on a Zoom call yet during quarantine, I will be shocked. But in case you don't know, up at the top or the bottom, depending on where your little panel is, you'll see a Q&A button. Please make sure you're asking any questions that you may have. We will have a question and answer period, but you can write those questions in whenever you might have that question pop into your head. This is being recorded. If you do not like being recorded, please kindly hit exit because we're going to record it. And last but not least, this replay will be out tomorrow. So if you missed it, or if you have a coworker that maybe couldn't make it, or if you want to send this to others, please feel free to pass it on. So we talk about healthcare being so expensive, right? And what I want to make sure that we set the framework on is a quote that I've heard from somebody that says, you can't pay less for healthcare unless you pay less for healthcare. And so when we talk about that notion, we talk about different ways of actually reimbursing for services that are being provided. So today, you probably utilize a BUCA. When we say BUCA, Blue Cross, United, Cigna, Aetna, Humana, a carrier. You use that carrier, and that carrier has their negotiation with the hospitals and the providers. Well, that negotiation dictates how much do you pay for the surgery? How much do you pay for that inpatient? How much do you pay for that MRI? What we're talking about right now is a form of alternative reimbursements. We're not letting a carrier dictate how much is being reimbursed. We're having a conversation about going direct. What does that mean? That means having a direct relationship or a direct contractual relationship with a service provider, a hospital, an imaging center, whatever the case may be. So I want you to think about a couple things. Why do some of the most innovative companies out there do it? Boeing, you'll see here an article, and it's phenomenal of the results that they've been able to achieve. We've got GM. I love the quote that Warren Buffett says that the car manufacturer, I think they were talking about GM, it was either GM or Ford, that basically says they're a healthcare company that has a automobile company attached to it. They spend more, which, and I love Howard Schultz's quote, we spend more on healthcare than we do on coffee. The CEO of Starbucks realized this a couple years ago, that they spend more on healthcare than they do on coffee. And so the reality of these conversations that GM has there in Detroit with Henry Ford Hospital is they've got a direct contract. They don't allow an insurance company to dictate how much they're spending on for what. And one of the best scenarios on there that I think is really interesting for people to think about is the reality of what Walmart does. Let's take orthopedic as an example. Walmart has centers of excellence across the country that they only allow their employees to use for orthopedic type services. So let's say you're having a knee surgery. If you're having a knee surgery and you work for Walmart, the chances of you having that surgery in their home office there in Arkansas is probably zero. They're going to actually fly you on the Walmart jet and fly you to a center of excellence. Why? Because the quality is better and the cost is better. And that is not a reality that they could achieve with the insurance company. So if you think about that conversation we just had, the cost of healthcare, what do we pay for healthcare, has historically been decided by these two organizations. On the right, we have the hospitals and healthcare system. On the left, we have some boring insurance companies building. And if you think about it, do the insurance companies have a vested interest to help your clients save money? I want you to think about this. What your clients or you as an employer, if you're on this call, if you wake up any morning, do you look at lowering your revenue? It's a rhetorical question. I know it seems silly, but when we think about it in the health insurance arena, what you call premium, the health insurance company calls revenue. And so tell me, what is the financial vested interest of somebody who is talking about their revenues lowering it? This is a perfect example of why this doesn't happen. And the reality of it is, this is the insurance company's stock prices since the beginning of Obamacare. I only wish my 401k was actually performing this well, because the reality of it is it wouldn't be underwater. So when we're talking about going direct, I brought some industry experts that spend 100% of their day constructing strategies that help employers go directly to health insurance providers without an insurance company in the middle. And I think you will be blown away at some of the examples and ways you could do this. So I'm going to stop talking here and let the experts speak. So I want, first of all, you guys to introduce yourselves. So Carrie, let's start with you. Let me know about you, your company, and what's the number one thing you want our audience today to take away from our conversation?
Sure. Well, thanks, Lester. So again, my name is Kerry Smith. I'm the Chief Network Officer for Employers Health Network. We're a national company. We're based in Charleston, South Carolina. I happen to be in Orlando, Florida. We build high-performance networks for self-funded employers around the country. We'll talk about some case studies later about where those are. And I think the number one thing I'd want you, particularly as an employer, to think about is you may have had good service generally, but are tired of the approach of necessarily using a carrier as a solution for how to do administrative services and to provide you with access to a network. There are other ways to do that through approaches like ours, which have been very successful and are saving a lot of unit costs and working our way towards value-based pricing that can help you have a longer, more sustainable yield and help you at renewal time and help you save money and also get excellent service to your employees.
Awesome. Awesome. And Rob, tell us what Everyone Health is, what you do there, and what's the number one thing you want everybody to take from your part of the conversation today?
Sure. Yeah. So Sono Surgery is a bundled contract. We're the largest, in fact, bundled contract provider. We have bundles for labs, imaging, and myriad procedures, everything ranging from MSK, spine, all the way down to gastro and other things. Everyone Health is the entity through which we deploy those contracts. So the thing I'd like everybody to walk away with is that when the existing system today, you go purchase something, you get a bill for it 60, 90 days later. You have no idea what it's going to cost. Our model at Sono and Everyone Health is, oh, you need a colonoscopy? Oh, okay, well, you can go here and you can pay exactly this price. You can pay this price in 6 months. You can pay this price tomorrow. Everything is fully transparent and bundled. So there is no getting pinged 6 months later, 3 months later, getting multiple bills. Where are these coming from? I thought I paid the doctor already. So we're trying to do away with all of that and change the entire healthcare system.
It's really funny. I love the word transparency, which, people throw around a lot, but it's not something that, if you think about it, is in the healthcare system today. So as we go to today, if you hear nothing else, I want you to hear this, that the conversation that we're having is a win-win-win. For the employer, they're saving significant money while, as you'll hear, adding a better benefit to their employees. Better benefits at a lesser cost is 100% an opportunity. You just have to look at things differently. The employee, as you'll hear, gets better service, gets more expertise, and more often than not, pays zero or something significantly less than they would pay under a traditional scenario. And the providers love this. They get paid directly, they know who their client bases are, and they don't have an insurance company sitting in the middle that they have to fight with. So the reality of the win-win-win is a phenomenon that makes this an absolute no-brainer for you to listen to. A couple of other things. A hospital is essentially, at this day and age, a collections agency. If you think about it, over the years, has your deductible gone up or gone down? Well, as your deductible goes up, and the average national deductible right now is about $3,500, but the average person doesn't have $400 in the bank. So when your employee goes to have a service, the chances of them paying 100% of the service is zero. So they are now going on a payment plan with that hospital, and now that hospital has to chase. And I think Carrie will actually correct me that my number is understated later, but reports show that hospitals spend between 30 and 50 cents on the dollar trying to collect that dollar. So when we have conversations about them going direct, we can waive that dollar. They don't even have anything to collect. So it's going to be a great opportunity. And you as an employer in your marketplace have a relationship with local healthcare. Every mission statement of every hospital is to improve the health of their local community. And that relationship is something that is very powerful. So I want you to imagine that we were sitting here, the three of us, and there's a fireplace, and we are all with a snifter of brandy or, bourbon or water, or Carrie's drinking a coffee, whatever it might be. But the reality of it is we're going to run this kind of like a fireside chat. And so I don't want to present a bunch of slides. I want to have a conversation so that we can understand a couple of things. So we're going to start with the basics to make sure everybody understands what it is that we're talking about. So first question, Carrie, when we talk about setting up high performance, setting up direct contracts with a hospital, what does that even mean? Walk us through the 101 behind that.
Sure. So direct contracting really is a construct of putting together the pieces of the puzzle that you need to be able to provide access to a network and all of the things that go with that an employer who's self-funded needs, who doesn't necessarily want to go to a carrier. So if you think about what those components are, and I'm going to speak inevitably about our company, but there are other companies out there that do that as well. But with EHN, the way we do that is we work with your advisor. He or she may have a third-party administrator that they really like. We have preferred ones that we work with if there's no preference. But we can work with the advisor and work with you to put together a selection of services that include access to a network, which we'll talk a little bit more about, third-party administrator services, utilization management, case management, analytics, and all the things that you need to support the program. The reason why these are put together is we have found over time that although in many instances, well, it's easier to say what do carriers do a good job of. Carriers are great at being insurance companies, but the way they have built their networks, it's very difficult for them, and I know we'll probably get into this a little bit more, it's very difficult for them to do, or almost impossible to do something like what we do because of the fully insured business and how that kind of skews their worldview, and that happens to be where they make a lot of their money. So really direct contracting is a way of putting together the constituent pieces that you need to have access to something which is going to save a lot on unit costs, give your folks access to what they need, give them access to something which is going to be very responsive at solving problems, etc. I would say it's buying a la carte, but it's really not. We kind of put everything together that's part of a meal. that replicates what you would get from a carrier, but it's just much less expensive. And the satisfaction level is generally much higher. In fact, looking at our renewals, our average every year, if you look at the inflation pattern for our networks, they're usually somewhere in the 2.5% to 3% range. We actually have a couple of employers that are getting their renewals for this year that have gone negative 5%. And that's not because of utilization or lack of it that happened with COVID. That's on a dollar for dollar basis. They're actually spending less year over year as their employees get used to using the network. And that's something with which we help. That's the basic version anyway.
So, summary of that, it is a network and it is an insurance program in a box. There are different components of it, but employees are going to get the same, if not better, access to healthcare at a cheaper cost. And the insurance company isn't having to be in the middle of it. Fair?
Fair.
Perfect. So Rob, bundled pricing. So we understand the word bundled, but talk to me exactly about what that means in it's a level 101 basis.
Sure, happy to. So the example I mentioned a second ago is very appropriate. So if anybody has ever been to a hospital for a procedure of any kind, they are probably familiar with getting multiple bills and EOBs. So when you go to the hospital, you might be seen, and the hospital might be a network, or it should be, presumably if you're in an insurance kind of environment. Your provider, your physician, the surgeon should be in network, but there are instances also where, the anesthesiologist was from a different group and they're out of network, right? And so, and the implant that they used for your knee replacement was actually, that was like another $15,000 instead of just being part. So all of these component pieces are what patients get charged. And they come in, really, they can come anytime, the day after the procedure up to, months afterwards. And so what Sano has done is gone out and to all of these providers, primarily surgical hospitals, ambulatory surgery centers, and we have said, hey, give us a total all-in bundled price. So if somebody needs a procedure, a patient walks in the door, they give them a little voucher thing that we've produced for them, and they say, oh, great, this is awesome. There's zero copay, zero out of pocket. I don't have to pay anything right now. The way we prefer for the employer to set it up is the employer covers this 100% because, and the reason why is this. So nationally, there are many places where a total joint, a knee in this instance, like I'm using here, is about $80,000. In an 80-20 plan, the employer pays 80% or $64,000 of those dollars, and the employee patient is left with the other 16, right? But I don't know any employer that wouldn't want to pay 100% of 22,000 or 21 or 20, whatever our contracted rate is in a given market, versus 80% of $80,000, right? So, and that's essentially how the bundle works, is all the things that are part of, it would be like going to McDonald's and saying, I would like a Big Mac, and then them saying, okay, well, that's going to be like $1 for the first bun, 50 cents for the second and third bun because you've already bought one bun. It's going to be another $1.25 for the patties, and like that. That's how the healthcare system works today. And we say, no, just give me one price. Let's make it easy. You're happy, you get paid quickly. Employees happy, they love it. They didn't have any out of pocket, and the employer loves it because we have now taken about 60% of their healthcare costs and slash those by between 40 and 60%, depending on utilization.
So it's funny, I literally wrote down this question to ask you, and you just said it. So when we look at the services that could be bundleable, if that's a word, that is in today's world, 60% roughly of an employer's healthcare cost. And they could save 40+%. So when we talk about math, I'm not a smart, intelligent person, but I understand the math equation on this. If I could take half of my services that I pay for and cut that price in half, I save a ton of money. And so this is what those conversations are. And guys, what I want to switch the conversation to for both of you is somebody's probably listening to this and say, okay, wait a second. You could go to the same hospital that United Healthcare is already contracted with. You can go to the same surgery center that United Healthcare is contracted with, and you can get a better deal. Why? Why doesn't United Healthcare do that? So help me out, guys, with this concept. And I want you to hit on why can this be done? And two, is this the cockroach motel? Or are we talking about quality actual healthcare facilities? Or are we talking about, hey, there's nobody in line anyway because nobody wants to go there, and that's why we're able to get a better deal? Talk to me about that. Rob, we'll go in reverse order. Rob, why don't you take that first?
Okay, certainly. So there's a couple reasons. I mean, number one, as you said at the onset, the carriers have a disincentive to lower premiums. So and I'm not saying, I'm not trying to make a blanket value statement about people in this. There's lots of good people in the industry that are really trying to do good things. They're just operating in a broken system. So number one, the incentives are totally misaligned. Carriers' incentives are to increase revenues, or as you said it, Lester, increase premiums year over year. And the way that happens is these expenses need to go up year over year. Where we have found tremendous success is with, and our model also has to do with working with the providers, not against them. So in other words, we don't go to a provider and say, we've got to have a lower price. What we say is we want to pay you a fair price. It needs to be competitive, right? It needs to be a bundled price. But what we find in the vast majority of cases is these providers are making very similar amount of money through us. The difference is we've peeled out the facilities charge and some of this other stuff. And generally we try and direct them to a private practice physician who's working at an ambulatory surgery center or a surgical hospital, or even just in their own private practice and in their office. Because the more physicians we lose to the massive health systems, the more they become employees and the more they don't have an incentive to say, okay, yeah, I'll give you a total bundled price and let's work together. And they have incentive to work with us because they want additional case volume, right? I mean, they're a business. When you think about a private practice physician or any one of these entities, ambulatory surgery center or whatever, they're businesses, right? And they need revenue. Well, for them, more revenue means send me more cases, send me more patients. And that's what we're doing is we're directing those patients to, hey, you can get a bundled price here. It's going to be a fraction of what you paid 2 years ago when you had your other knee replacement. Bam, it's perfect.
Perfect. And Carrie, take the same question. So let's play with, since you're in Orlando Health, one of the biggest healthcare providers in the Orlando marketplace. They're in everybody's network, but they work with you guys and presumably you get a better deal than what's offered in the marketplace. So I can understand if someone's not in this business, they ask themselves why. How do you answer the why part of that?
Sure. And I'll start with a little bit of the same caveat Rob had. This isn't intended to be negative or to denigrate the carriers, because carriers have their role. But if you look at what we did with Orlando Health, I appreciate you bringing up that particular case study. So with Orlando Health, there are two major health systems in the Orlando market. Orlando's got around a little bit south of 2 million people, I think, in Metro Orlando now. You got two major health systems. Orlando Health is a health system that we've known for a long time, and they were interested in doing a number of things. Why would they do a contract with us to do something that's 22% better unit cost than what they give their best carrier discount, which is probably Blue Cross or United? Why would they do something like that? There's a number of key reasons. Interestingly, I'll start off with the one that's a little different than the experience that Rob has. Rob's exactly correct. Hospital systems are buying up physician practices. If you look at it now from the hospital standpoint, if an employee can go and get the United directory and go to any hospital he or she wants, including their competitor, that's going to drive business away from the employed physician groups and the clinically integrated networks that they've developed, which are there not just to reduce unit costs, but also to reduce utilization. Because as we know, if you can control costs and you can also coordinate and calibrate what happens to someone, you don't wind up with somebody getting 2 MRIs in 6 months. What's the cheapest MRI? It's the one you don't do that you don't have to do. Orlando Health said to us, we want to get closer to the employer community. Apart from Disney and Universal, virtually every self-funded employer in Orlando is based locally in Orlando. Do a good job of servicing that population, give excellent unit cost, adjust the plan design where the out-of-pocket expense is less expensive, so the employee is compelled to actually use the benefit, which is important. And it gets you closer to the employers that are in your community. They realize that 22% savings doesn't necessarily, no offense to Walmart, but that's not going on to Walmart's stock price. That's going on to a construction company. That's going on to somebody who's got 500 employees that goes to the same church they go to, that's in the same community where they're located. It does reduce also that particular provider. Therefore, as we build the network and as we've been building more employers onto that, it also reduces the hospital's reliance on the large carriers. Hospitals realize they're going to get a lot of fully insured business and that the carriers are never going to narrow those networks. Politically, they can't. But what a hospital CFO never says is, I'd really like United and Florida Blue to have more buying power next year than they have this year. Anybody that's a hospital CFO wants to reduce the reliance that they have on any one particular payer. And if they can do that and have a great relationship and help out the employers that are in their community, that's really what they set out to do.
So I heard 2 things that I want to make sure that everybody understands on this. Is community and competition, right? I heard that in Rob's conversation. I heard it in Carrie's conversation. Without competition, nobody wins except the person that is creating the profit. I mean, this is a Jeff Bezos, your profit is my opportunity, right? The reality of this is he or she who has the biggest chance to win, a la insurance company, without competition, they win. So this is driving competition. And again, back to the mission statement and why everybody goes to med school. They want to do good. I truly do believe that everybody in this business gets up every day wanting to do good. They're just in a system that's broken and doesn't allow them to do as good as they could do. And so I think that that's important to do, to talk about. So, okay, we've got our direct conversation with a hospital, a surgery center. We can save 22, 30, 40, 50% on the unit cost of these things. I've got 2 questions, guys. One is, wait, is this only for the Walmarts of the world, right? How big do I have to be to get this? And then follow that up with a case study of your everyday client that is utilizing these types of plans. And I'll go in the reverse order. Carrie, why don't you start with, what's an everyday client look like? Because debunk that myth that the only people that can get these types of deals are your Walmarts, your Disneys of the world, et cetera, et cetera.
Yeah, that's a great question. So actually the really large employers like the Walmarts of the world are actually very difficult to service with a plan like this because they have so many locations. They have to build a network and usually have to use some national network like a United because they don't really have another option. We've got an employer that we've worked with that is a larger employer that has broken that out, and that's Whole Foods. Whole Foods uses us in New York, Los Angeles, and Austin, Texas, and they actually broke away from their larger plan. But I would say that's pretty hard to do. Really, our target market is anybody that's large enough to self-fund. In Orlando, may vary a little bit where you are around the country, but in Orlando, probably any employer that's north of 175 or 200 employees is typically self-funded. We love those. They usually are very appreciative of having the opportunity to save money because they don't have critical mass like a Walmart, aren't big enough to have their own clinic strategy or anything like that. But we're in a position to help them bring those in. And that is, if you look, our average size employer nationally probably has between 175 and 300 employees. And we'd always rather have 20 of those than have one 6,000 life group because it spreads the risk and it also accomplishes what the partner health system wants. And they're not just interested in revenue, but what they're interested in is getting more of the outreach and get the employees and the employers more attuned to and experience with what they can provide. And that spreads the word much more effectively than having a large employer that might be based 3 states away.
Perfect answer. And it makes such intuitive sense when you're on our side of the business, but I can completely see an employer sitting there saying, wait a second, I've got 150 employees. Why do they care about me? But the reality of it is the economics is not the only thing. And the reality of it is that aggregation is such a big deal. So Rob, again, same thing for you. So I know in California, you have some big clients and you got a lot of the tech companies out there as clients, but I myself have a 18 life group that uses you and a 10-1 group that was 67 lives and saved 87,000 the second day of the plan. So walk us through why that surgery center over there has the same surgeons as the hospital over there, but you can get the same exact procedure done for half the price. Walk us through that mentality.
Sure. So, same surgeon is going to have hospital privileges right at the local hospital, but the hospital has a different. I won't even use the word charge master because my head's going to explode when I start talking about that, and nobody needs to know what that is. But hospitals have a very different way of pricing things and a very different way of getting compensated for those services that they sell. In an ASC or a surgical hospital, it's very different. Usually it's owned by the private practice physicians. So they're all owners in this entity. And so when, anybody who is a business owner understands fundamentally you view the world completely different, right? You have the mantle of responsibility for your employees, for bringing revenue in the door, for keeping expenses low. And so that's how these individuals, these men and women that own these facilities, that's how they think. So they're like, let's get revenue in the door. Let's do a bundle. We'll do it any way that we can, right? I mean, and so again, their incentive is aligned to our model very well. The other thing that incentivizes them is that we compensate them faster, much faster in many cases than they're currently getting paid in the existing broken model. So I'll stop using the total joints one but I like that one so much. But colonoscopy, for example, right, is not a super big. Well, we can use this one, Lester. How about you go to the next one, the imaging, which is a very common. This is CT of the abdomen and pelvis, right? So this was an analysis that we did for, and this is typical of most of our client sizes. They're between 1 and 3,000 lives. Our smallest is, Lester, as you said, we've got a number of them that are under 100. And then we got some that are very, very large. But this was a 2,200 member. So these were about 1,000 employee life group. The CT, the range that they paid the prior year was between $450 and $6,000, which that just sets my hair on fire. And the problem is there is no correlation, right, of quality to the price paid. I mean, they've tried to do studies to demonstrate that, and they can't find a correlation. So the average price, obviously, $1,363. Total plan cost $62. Our price is $350 at Everyone Health. So saving them $46,000. And again, bear in mind, this is one item, one singular item. So magnify that times every other kind of imaging service, tons of lab procedures, dozens of surgeries.
Rob, I got to ask the question because I have heard this anecdotally before, but a CT machine, an imaging machine, right? The thing I sit in or go in, whatever, to do the deal. Is it the same exact machine at the Independence, procedure place over here versus the hospital? I mean, debunk that truth or myth or whatever, because I've heard there's only a couple manufacturers of actual imaging machines. It's the same darn machine, because then back to blowing up your mind, how is the price difference if it's the same machine that's taking the picture, theoretically the same exact tech that went to the same tech school reading it? Is that a myth or is that an accurate statement?
No, so you're right. It's the same machine, probably even the same brand of machine. GE is a huge manufacturer of items like that. But it's the same machine. Techs went to the same school. So, and this is usually where we talk about our providers and how we select them. But all of our providers are board certified and fellowship trained. And we've got, I won't bore people with the details of that, but what that means is they're very, very good at their job. They didn't fall out of medical school yesterday. They've had additional training beyond just, their years of medical school. And we have, because we get asked this question all the time, right? Like, we were giving a presentation to a group of individuals and they said, well, are you sending me to the veterinarian? I'm like, no, our providers, they're extremely experienced. We have one guy in Oklahoma City that's been in our, we've had direct contract with for years, and he's done thousands, tens of thousands of these surgical procedures. So, I mean, those are the kind of providers we're talking about.
So, better quality, or at least equal quality, lesser cost. So, I want to make sure that I'm reiterating some of these points. Let's talk about a case study. And again, like, if you guys can think of an employer or even a member to bring it down to, because what I want everybody to get off the phone with is better benefits at a lesser cost is absolutely achievable. And so that better benefits at a better cost is both employer-centric, but that employer-centric is being employee-centric, right? And so walk me through a live example, each of you, of somebody or some, employer and the lift that they had to do. Because I would imagine the other obstacle in people's minds right now are, how much extra work is this on me, the HR administrator, having to do all of this? Well, talk to me about that extra work. Carrie, why don't we start with you?
Okay. That's a good question. That's a question that comes up often. We have experience in implementing these networks and helping the folks in benefits and HR get ready for open enrollment. You mentioned, we talked a little bit about larger employers before. Sometimes our experience, for example, with Whole Foods. Whole Foods actually elected to have 2 health plans in Los Angeles and in Austin when we started with them back in 2016, 2017, and 2018. And they carved out and had a plan you could go on. It was called Club Zero, because in many instances it was zero out of pocket. And that was the plan that we put together for them. And then they gave folks the option to go on to United. How we did the rollout with that is very similar to what employers have been doing for years, and that is having multiple options, whether they're fully insured or self-funded. So you've got the plan design, it's got $3,000 deductible and a $5,000 deductible. You can choose that plan, or you can go on to another plan that's got a $1,500 deductible and a $3,000 out of pocket. It's got a higher premium. Or it may be something like ours, which is a high performance network, which has not every provider in town on it. We used to use the word narrow network. We'll call it a narrow network. Go onto the narrow network and give folks a choice of what they like. Inevitably, I guess this blends into the case study too. First of all, in terms of presenting it, what we did is we educated the folks in HR and benefits about how to present the plan. In our case, we also had people available from our company who went to open enrollment to work in case there were any questions. And in the case of United being there as well, United had their folks there as well. So we had 2 tables, looked like a little conference, and talk people through it. Once we got started, what happened was the money that was saved was so significant that after 2 years of the pilot project, Whole Foods went in and basically terminated their contract in those 2 big metropolitan areas with United and made ours the only plan. Now, one other question that might come up is, well, That means you didn't have every provider in town now and everybody was now funneled into an Arrow network. What did you do about that? A couple of things. First of all, we can work with your company, you as an employer work with your advisor to have other types of things which can cover what happens if somebody goes out of network. And actually, Lester knows, has probably forgotten more about that than I ever knew about how you have wrap options and RVP options and things like that. The other thing we did is if an employee needed to go and they were out of town and they got sick and there wasn't a solution, we actually have a team of folks that work with us that do what's called single case agreements. They will actually go and initiate and negotiate a contract, usually at a very deep discount, with that provider in order to care for that patient. We've done that for everything from somebody getting hurt on a ski vacation in Idaho to someone that needed to go to MD Anderson to get specialized cancer treatment down in Houston, Texas. That's not the kind of thing that you're going to get with using a network option coming from a carrier. That's the kind of thing you're only going to get with somebody that's really a partner to you, that's paying attention to and interfaces with you every day to do everything they can to make the experience as good as they can for the member. Does that help, Lester?
In that example, I want you to hit on the economic piece of it. In that example, in that market, what was the analysis of the savings, not only for the employer, but what did an employee save if I chose this one versus chose this one?
Yeah, if the employee, the premium for the employees when it was an option, the premium difference for the employees was something like 26% less expensive premium to go onto the high performance plan. I would say unit savings. The last report I saw, we look at it, and the way a lot of brokers and consultants and even employers look at it is either a PEPM per employee per month or per employee per year. I think we were somewhere in the 26 to 28% less expensive than United, which is why they eventually switched everyone over to us. Results will vary, could depend on what market that you're in, could depend on utilization, a lot of other things. This has been an interesting year because the first 6 months of this year, there was no utilization. But we know when we put our contracts together that the unit cost is guaranteed to be a certain percentage below that you're going to get on the broader market. And that's something that we talk to you about when we get, as we move along towards a partnership, that's something that we share with the consultants and the employers alike.
So again, recapping here. The employees got to choose what they wanted to do. They spoke with their wallet, which employees always do. They got into a plan. They didn't hate it. They didn't revolt, and they saved 25, 26%. The employer saved 25%. I'd like everybody to remember the time that your health plan generated any savings. We have redefined the word savings in our business to be the less crappy renewal. It came out at 20. I brought it back at 10. I saved you 10%. Last time I checked, that is not the actual word saving. So the reality of this is actually a true savings and needs to be thought about that way, paying less in healthcare next year than this year. So Rob, same thing. Walk me through an example. I'm going to say one specifically with you guys in Sano because it's my favorite testimony I use all the time, but I want to hear one maybe from something a little bit more serious. So we've talked about joints, we've talked about MRIs. What about something a little bit more serious, something on the higher end of the spectrum?
Well, so I was going to actually go the other way because
okay. Well, you go the other way because I'll go on the higher end.
Okay, that's perfect. Yes, you take the high road, I'll take the low road. Sounds good. Okay, so there's one that this one I love because we were talking about this just in the lead up before this call started, and it something that you said reminded me of this instance, and that's why I wanted to say it. So, and I posted about it recently on my LinkedIn feed. So we have among our clients is a group of firefighters, and if you're familiar at all with firefighters, they're not making 300 G's a year, right? They work extremely hard. They put their lives at risk for people like us on this call, right? I don't remember this guy's exact compensation, but it was around $50,000 a year. So like that's again, you start talking marginal differences in premium or marginal differences in out-of-pocket costs. And for people that, that work that hard and that are compensated that way, that makes a difference. So this gentleman's daughter needed imaging services, had gone to the doctor, and the doctor said, oh, hey, go downstairs. There's an imaging place right at the bottom floor of this building. While he was on his way down in the elevator, he messaged one of our care guides, and she directed him to one of our imaging facilities. It saved $2,500, and he had zero out of pocket. And to me, that's the best part of the story, right? It's like, okay, awesome that the employer saved money, because that's what we're trying to achieve. But the other part of what we're trying to achieve is make healthcare affordable for individuals like this gentleman.
So I love that conversation, because as somebody who's experienced a lot of healthcare with my family, both my parents have had cancer. At the end of the day, it topples families. I mean, we had to file bankruptcy, and the stats are 68% of all personal bankruptcies are because of health reasons, and over half of those people had insurance. Mm-hmm. Again, if we talk about a $3,500 deductible with $400 in the bank, those numbers don't add up. You'll never be able to pay that. So the example I want to give, I'm going to give two examples. I'm going to read a testimonial, because if you're an employer out there, this is what you should be thinking about. These plans are designed that when your employees work with the advocate, so Rob just mentioned an advocate, a care navigator, somebody who has this information and can help guide the employees to understand where they can go access healthcare, the reality of it is magic happens. And so it's a confusing thing to navigate the healthcare system as it begins with. The cost and the quality of healthcare is completely different. But when it works, the result, you save money, and your employees most of the time have a $0 out of pocket. So I want to read this, because this is something I post. Today is what I call Testimonial Tuesdays. And so every Tuesday on LinkedIn, I post something. It says, this is an exact email from a member. It says, I'd like you to forward my email to your supervisor. They were writing an email to their advocate so that they know what an outstanding person you are. I've been trying to see a surgeon regarding my severe pain in my right shoulder since last July. When our new insurance started, you took over my case, and you made sure I was finally able to see the surgeon and got the approval for my total replacement shoulder surgery. You are kind and courteous and attended to all my needs. You helped me get my MRI when the surgeon stated I needed a CT scan before surgery, you helped me get that too. I am now pain-free and paid $0 for my surgeries and my scans. I'm actually in tears writing this. I didn't like the thought of having an advocate before, and now I couldn't imagine not having you. I mean, if that doesn't fire you up to get out of bed to do what we're able to do, and you as an employer to be an employer of choice, imagine if you're sitting there having a conversation about the recruitment and retention of your key employees and being able to say, we provide a health plan that has a navigator, has an advocate, has a care coordinator. They're called different things, but that person's there to help you shepherd the healthcare system. And when you comply, you're getting to the best quality of healthcare at the lowest cost. I mean, it is a story that is different. Mentality is different because we haven't thought about accessing healthcare. The story I was going to tell you was a CEO of mine. And this happened, the group is in Phoenix, Arizona. And if you understand Maricopa County, you have a bunch of great healthcare. And that healthcare is super expensive in a lot of places. You've got the Mayo Clinic, you've got Banner, you've got Dignity, a lot of great healthcare. So we had a CEO that was having a heart procedure. Long story short, $196,000 at the Mayo Clinic. And we were able to get him a bundled price through Sano at Oklahoma Heart Institute. So one homework assignment that everybody has is to look up this institute, Oklahoma Heart, hence where it is, Oklahoma, but they only do hearts. So hence the name, and you can actually look at prices on the internet. So the reality of this is after the CEO himself talked to the surgeon got the HIPAA information, the CEO, decided that he was going to get on an airplane, fly. We flew him first class with his wife and their dog. Long story short, it saved the plan over $80,000. And the CEO made his own decision because at that point, it's left pocket versus right pocket. Both pockets are his. He's the CEO. So the reality of this is just such a big difference. But what I want the employers and the advisors on this phone to get from this conversation is this is all possible. It's constructed inside of the PinPoint plans that we have constructed with AccuSure, and it is available for all size clients. So here's the last thing I want to do. The last thing I want to do is what I call parting shots. And those parting shots, guys, what I like everybody to do is say, okay, we've all sat through these things before. We go back to our desk and then life happens, right? We get bogged into the normal day-to-day. What's the number one thing, Carrie, that you advise employers, advisors that are on this call today? What's the number one thing you want them to think about, do different, whatever, when they get back to their desk?
Yeah, I'd say broadly, just educate yourself, work with your advisor to educate yourself about all of the options that are out there for things like what Rob has presented. Hopefully things like what I've talked about today. There are a lot of other options out there, and it may look initially frightening to move away from kind of the typical approach of going with a carrier for your solution, but don't be afraid to ask questions or to talk to Lester and to talk to others about how we can help you. There are a lot of other innovations out there, not just the ones you've heard about today. Lester's aware of a lot of those. There's great opportunities out there to do things which are going to save money, make your health plan more sustainable, and allow you to continue to offer a health plan, even if you're in, even if COVID and the economic downturn has affected you. It could be the difference between having a plan that's affordable and having no plan in some cases, and we certainly understand that, work with employers like that. So educate yourself, ask the right questions, and reach out and let us know how we can help you. We'd love a chance to talk with you.
Perfect. And last but not least, Rob, what's your parting shot, your mic drop moment, the one thing people need to remember when they leave and get off this call?
Well, so I'll answer that with two brief statements, Lester. So the first thing is, everybody knows that expression, the definition of insanity, right? And I think that applies very appropriately and accurately to what's happening in our healthcare system. Like, we keep doing the same things over and over, and yet every year we're surprised, that healthcare, there is an endpoint. At some point, this will get too expensive, and I put that in air quotes because it's really not. You just got to know what to do, who to talk to, and how to do a couple of things, and a couple of those things are what we've discussed on the phone. But you don't have to accept the same old result doing the same thing. The reason we exist is to change healthcare. I know I said that at the onset of my comments, and I don't say that tongue in cheek at all. We want to fundamentally change the way people purchase and consume healthcare. We are, and our founder says it this way. We want to, speaking financially, we want to reduce, stabilize, and hedge healthcare prices, and we found a way to do it. So I thank you again for the opportunity, and feel free to reach out. Lester, this has been a really enjoyable discussion. Every time the three of us get on the phone, I'm always, and it's in the afternoon during my sleepy time, post lunch, I always get off the phone more excited and fired up than when I started. So I thank you very much. I appreciate it.
No, thank you. And what's funny is this was not planned. This was not planned. It is one of my hashtags I use on social media.
That is awesome.
All the time, but I am shocked every day at employers who say, I am worried about change. And I want everybody to keep in mind, if you're passing on an increase, that is change. Most employees live paycheck to paycheck. They don't even have enough. They're probably in debt. They have less than $400 in the bank. And so passing on that increase because we don't want to change, this change actually allows something better where that change doesn't. So again, back to what Rob said about the definition of insanity. None of us do this. None of us get up out of bed every day because this is the easy way to do it. This is absolutely the right way, because we are improving the patient outcomes. And that's the first thing. If you get people to better quality and you finance healthcare differently, magic happens. So again, I want everybody to maximize your relationships. If you have a relationship with your local hospital, we can turn that into a great conversation with you. So again, just reach out. So a couple of things. The closing of this is I want to make sure that people understand the PinPoint structure in which these conversations that both of these gentlemen are experts at are embedded into is saving people, saving north of $2,600 per employee per year at the worst case scenario. I mean, it's an unbelievable conversation. You're not talking about paying more next year, you're talking about actually saving less money. So there's a couple things that we could do if you'd like an impact analysis to understand how these types of programs can impact you. Just let the person that invited you onto this know. And what's exciting about this is that we have gone through episode 3, episode 4, and this is episode number 5. Episode number 6, as a save the date, which is the closing one of the year, is forecasting for 2021. We are going to talk about the tools and tricks and tips that you need to start doing in January, so you're not stuck in the same situation that you're probably stuck in right now, which is, I would have liked to do something different, I didn't get presented any options, or it's too late, or whatever, all of those things. What things should you be looking at in 2021 to be able to do that? And if you're interested, if you were a January 1st renewal and you're sitting here saying, man, I could save that kind of money, I had no idea, it's not too late. It's going to be a little rushed, but we can absolutely do it. And the reality of it is, please contact the person that invited you. If you have any general questions, the email address here on the bottom left-hand corner is one that you can contact the team, and they will be able to work with you on that. Gentlemen, Carrie, Rob, thank you so much for your passion about changing healthcare. Obviously, we have that common thread and denominator amongst us. Thank you for your speaking and your insight. To all of the audience, advisors, and employers, thank you so, so much. Please do this. Demand more from the people that help you out in your healthcare program, and you can actually make change. So thanks so much, everybody. Be safe, and we'll see you in December. Thanks so much.